minute numbers for you. All right. So I'm not going to focus on every slide. We're going to hit just kind of the high points on a few of them, and I will do my best to attempt to illustrate kind of what the other stuff is as we go along here. Some of the stuff that I think is really important. Okay. So one thing to kind of remember as you guys go out and work in PT clinics and OT clinics and you want to be medical professionals is if you think your internship is bad and you have a poor job, just know that if this was 100 years ago, your job would be the urine taster to diagnose people as being diabetic, okay? And so it's called diabetes because the main method of diagnosis was through inspecting patients' urine, which was sweet and fragrant. If you have elevated blood glucose levels, one of the ways to try to lower that is by increased excretion of glucose at the kidneys, leading to high levels of glucose in your urine. How does one know if you have high levels of glucose in your urine? Some poor soul has to taste it. Okay? That is actually 100% for real. Yes. So, one, if you found a person that had uncontrolled diabetes, yes, their urine would be sweet. So, you know, you could drink urine, it's not going to kill you. Right? I didn't say it wasn't disgusting, I just said that it wouldn't kill you. Right? But that is a way that we could diagnose things. So that's where all of this has, in some ways, been derived from. Okay? All right, so now this doesn't want to work. Here. Okay. So in the present, you guys did a very nice job of this. Being a diabetic, it's a metabolic disorder. It is very specifically a disorder of carbohydrate metabolism. Okay? A disorder of carbohydrate. And so what you're getting from all of this realistically is you cannot properly use carbohydrates or sugar, right, that is coming from food that you have ingested. Okay? So this is likely going to be the case though. So if this is what's sort of going on, it is due to disturbances or improper insulin function. Something is wrong with your insulin function. You're not making it or we're not using it properly. Okay? So as we said, the cause or mechanism of getting at this insulin dysfunction is different based upon if you're type 1 or you're a type 2. Okay? So type 1 used to be called juvenile onset or what we would call insulin dependent diabetes mellitus, okay, IDDM. This is the sort of least prevalent cause, okay? But it used to be called juvenile onset because most people that are going to be a type 1 diabetic, it will come on and it will occur for the first time, or they will get their symptoms while they are, you know, maybe in their sort of late adolescence, kind of early teenage years, okay? You'll see some people that are going to be into their early 20s, but for the most part, it comes on very early in life, okay? So with this, insulin is not going to be produced in the pancreas. Therefore, I cannot drive glucose into my cells, and that's going to lead to a host of kind of cascade of other problems, okay? Meaning the liver is going to have increased glucose output, but I'm also going to have to rely increasingly on the breakdown of fat and using fat for energy because I cannot metabolize carbohydrates, okay? So the really, and this one is not a thing to, this is not a kind of a no joke thing, but we have reasonably good, if people can afford it, treatments for this. You can monitor your blood glucose levels and be very careful. You inject yourself or you have a pump to give you insulin. Although insulin is outrageously expensive if you don't have insurance these days. I'm trying to remember who it is that holds the patent for making the insulin. It may be Merck or someone, one of the drug companies, but it's really, really expensive. But with some care, this one can be reasonably well controlled and monitored, and you can be okay. Type 2, on the other hand, we used to call it adult onset. We don't call it adult onset now because every year it gets increasingly more common that people that are y'all's age or younger are becoming type 2 diabetics. Okay? This used to really only be a disease of people that are older. It is no longer the case. Okay? The key thing that is wrong with you if you're a type 2 diabetic is you are insulin resistant. And so resistant means your tissues that normally bind insulin and then bring glucose in no longer respond to that insulin. Okay? They no longer respond. The body makes plenty of insulin. Your pancreas dumps more and more and more insulin into the blood, but the tissues that normally respond to it do not do so anymore, or do so at a lower rate. Okay? That is what it means to be resistant to insulin. So I eat something, my blood glucose goes up, my pancreas releases insulin, and then I'm gonna, because I don't respond to that insulin, I have a less great ability to take up glucose into my cells. Okay? Now, early on in people that are type 2 diabetics, they can usually find a way to get glucose into their cells. Okay? But it requires way more insulin output than a regular person. And so over time, this large increase in insulin production can wear out the pancreas and wear out the beta cells. And you may be a type 2 who becomes a type 1 over time because you wear them out. Okay? So that's sort of what's going on. Okay. So who is at risk of becoming diabetic? And to be honest, really anybody in Western society these days is at risk. But there's a cluster of risk factors, especially those for type 2, are going to look really familiar to you guys. Okay? Type 1 is immune mediated. It's an autoimmune disorder. It's a genetic kind of thing. You're at a heightened risk if you have a family member that is type 1 diabetic. Okay? Type 2, hereditary, so there's a genetic component. Obesity, abdominal fat distribution, age, being sedentary, having high blood pressure, having elevated cholesterol levels. Does this look like something else we just talked about? What does this look like? Kelly, you're nodding your head. What is what?
Factors.
4? We just talked about. Can someone help? Kelly, what did we just talk about? Cardiovascular disease, right? These look like the risk factors for coronary artery disease. That's because if you have coronary artery disease, you're also probably going to be a type 2 diabetic. You're getting really close. So these things are all going to cluster together. Okay? So this is the big thing. Being sedentary, being obese, okay, are the really, 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 in combination with age, the really big risk factors for this. Okay? We'll talk about why that's going to be the case. People don't talk about this as much anymore, but if you do any kind of research into type 2 diabetes and cardiovascular disease, you will learn about something, and you will find something called metabolic syndrome. Okay? Metabolic syndrome. Or it has sometimes been called metabolic syndrome X. Okay? And what it is a clustering of type 2 diabetes, high blood pressure, obesity, and elevated cholesterol levels. Okay? So we see lots and lots of people. Basically, if you're a type 2 diabetic, there's very, very likely you're going to have high blood pressure, you're going to be obese, and you're going to have elevated cholesterol levels. And so the issue with all of this, okay, is that if I'm a type 2 diabetic, I am very likely going to die from cardiovascular disease. It's not going to be the diabetes that kills me. It's going to be the comorbid cardiovascular disease. And so that syndrome, that metabolic syndrome, is the thing that is now kind of afflicting all of kind of American, European, what we think of as sort of typical Western society, because we eat too much and we're not active enough. And then all of those things are going to go together. And it causes us huge, huge, huge amounts of healthcare costs. Okay? Okay, we talked about this. So about 10% of the world's population right now are type 2 diabetic. 10% of the world's population. Okay? Most of those people are in like first world countries. Okay? Europe, Russia, the US, India, China, Japan, Brazil. Okay? Most of these people. Type 2 diabetes is not a thing in lots of third world countries because people are much more active. Okay? Unfortunately, people have less access to food. And so there are things about sitting behind a desk, looking at your computer, watching television, and eating McDonald's that unfortunately plays a big role in this. This number has gone up dramatically over the last 30 years. Dramatically. Okay? So we talked about type 1, we talked about those kinds of things, right? Okay. Much, much smaller proportion. Okay? Type 1 diabetes accounts for about 10% of all diabetes cases, so it's about 1% of the world's population are type 1 diabetes. Okay? So type 2 is much more prevalent, and in some ways it can be much, much worse. Okay? So one of the things that we do now, if you're a type 1 diabetic, is we give you artificial insulin. So here's a picture of a little guy named Ted Ryder, and here's Ted in 1922. There's Ted in 1923. Ted was one of the first patients to ever receive insulin infusions. He was given insulin that was extracted from dogs. And so what you can note here, in 1922, right, little man is kind of really gaunt and very skinny. And then in 1923, he looks much more like what you might expect of a kind of a young child in some ways. He's a little more plump, right, and those kinds of things. Most of this is driven by, here, he didn't make any insulin. He could not metabolize glucose. And so his body was deficient in energy in that way. And we do all of this here. He gets the insulin, and voila, he's able to metabolize things. He's got enough energy, and he looks much more like what we would expect normal kids at that age to do. So the discovery of all of this was done by two fellows named Banting and Best. Here they are with their diabetic dog, Marjorie, who was there. And so they were studying this in dogs, and they figured out, let's give a human some dog insulin and see if it actually works in that way. So we think about all of it. That was 100 years ago. Okay? That was 100 years ago. So it's not that long that we've been doing these things. It's important to note there's lots of complications of diabetes. Okay, the big thing is having chronically elevated levels of glucose in your blood makes the kidneys work harder. It makes the liver work harder, and it changes blood pressure and things, all of which are going to increase our risk of cardiovascular disease, hypertension, stroke, kidney disease. Okay, the what we call hyperglycemia, so the elevated blood glucose levels, that tends to damage capillaries. It damages small blood vessels, and it tends to damage those blood vessels in the kidneys, in your eyes, in your hands, and in your feet, like out in the extremities. When blood vessels get damaged, it cuts off blood flow to nerves, and you get what we call neuropathies, which is nerve damage. And depending upon where those nerves are, if those nerves are in your eyes, you go blind. If those are sensory nerves in your feet, you get excruciating burning, shooting pain in your feet. It's called a diabetic peripheral neuropathy. Okay? You get damage to blood vessels in the kidneys, you get kidney damage. You have to go on dialysis. Improperly functioning kidneys are one of the worst things that can happen in everything. The complications are really, really nasty. Okay? Zach? I don't know, Zach. If you can answer that question, they will give you a Nobel Prize. I'm serious. I'm 100% serious, okay? So you get nerve damage, and it's now not that the nerve doesn't work, it's been damaged, and so it's like it's turned on all the time, or those kinds of things, okay? And these are, I have been told, or if one reads into this, some of the most painful, most excruciating things that can occur sort of to anybody at any point, right? And this nerve damage. Morphine sometimes doesn't cut it. There's not good drugs for this. The nerves are just firing because they've been damaged uncontrollably. And it's really, really rough. Katie, do you have a question or comment? Mm-hmm. Yes. Mm-hmm. There's nothing that can go on. So nerve pain is due to either inflammation in the nerves, irritation in the nerves, or damage peripherally like this. Nerve pain is one of the things that drives the opioid crisis in those ways. Because anybody's ever had like significant nerve pain, I have issues in my neck, and you get like, you think like, oh, how bad can it be? And you get this like shooting pain down your arms or in your back or in your hands or feet or someplace, and like you just can't do anything about it. Like I can remember sitting up at night with my neck pain and stuff, like with stuff shooting down my arm, and just sitting there like you can't get comfortable, just sitting there crying, just being like, I want all this to stop. Just like there's nothing that you can do, right? And so one of the big things is they prescribe Oxycontin or those kinds of things, and it's really, really, really tough. Okay. Diabetes is one of the leading causes of adult onset blindness because of damage to the ocular nerves. It's also one of the leading causes of amputation, especially like feet and those things in adults. You have poor circulation, you get nerve damage, you get tissue damage and things because there's not enough blood flow going there. I'm not 100% certain if I have the picture of the bed sores on the feet that are in here or not, but there's some really, if you're into that kind of thing, just like Google diabetic foot amputations and those things, and you can see some really awful and terrible things. Okay, so treatment for type 1, it's really medication. It's really medication, and then being cognizant of what you're eating. For type 2, it's some combination of all of these things, which we really want to try to focus on these bottom two, on diet and physical activity. Okay, so what is, and I meant to look this up today, and I apologize that I did not, but one of the 2 or 3 most widely prescribed medicines in the entire world is something called metformin. And metformin is a drug that we give to people that are type 2 diabetic, okay? And it is called an anti-hyperglycemic agent. What metformin does is it allows your cells to respond better to insulin. And so I'm a type 2 diabetic. My cells don't respond that well. I give you metformin, and magically you're going to respond better. And so it helps to lower your blood glucose levels. It helps to lower your insulin levels in response to immunity. Okay, it's one of the 2 or 3 most widely prescribed drugs in the entire world. Okay, but there's a host of things that are going to do those kinds of things. There's some other drugs that increase insulin secretion, which we don't normally like to do. Most type 2 diabetics, they make plenty of insulin. We don't need that. What we're really doing are these insulin sensitizers. Weirdly enough, there's a little bit of evidence, it's not super compelling, but a little bit, that if you take the spice cinnamon, it improves your insulin sensitivity. Okay? It will also likely give you heartburn and upset stomach if you take all of those things. So I spent part of my postdoc, we were doing stuff with ginger for some muscle-related things, but in the process, we had to learn about all these other spices that McCormick was trying to sell, and there's some stuff on cinnamon. There's some fascinating stuff on pain and red pepper. Red pepper has something called capsaicin, which makes it hot. But you put that on and it's hot and it hurts, and then it depletes something called substance P, and then you don't feel pain nearly as much for a while afterwards. We actually tried some of that for some exercise-related pain stuff, and we just gave everybody indigestion and diarrhea and things, because it's just like all you're doing is just you're having hot wings all the time. And it's not a great situation. But there may be some things that we can try to figure out in the midst of all of this. But the idea is make the insulin that you make work better by further sensitizing your cells. Okay? And this piece of things, okay, making the insulin that you have function better is the key thing that physical activity does. So medications for type 1 diabetic, it's mostly just going to be insulin. A lot of people nowadays have these continuous blood glucose monitors. They put the things in and it monitors, and then it's hooked up to a little pump, and that pump has insulin in it, and so as your blood glucose goes up, it releases insulin. Blood glucose goes down, it stops releasing insulin. So there are some things that we can do there. Okay? So some of the things that are happening. If I'm hyperglycemic, so I'm not driving glucose into my cells, I'm going to have polyuria, okay? I'm going to have weakness, impaired vision, changes in mood. I'm going to, because I can't metabolize my carbohydrates because I can't get them into my cells, you go into something called ketosis. This is the same ketosis that people that go on the keto diet are attempting to induce. You're going to make these ketone bodies out of non-carbohydrate derived substances. Okay? Think protein, fat. Okay? And then you can try to use those ketone bodies and turn those, you can metabolize those ketone bodies in that particular way. The consequence, though, is people have this kind of sweet, fruity smelling or acetone smelling breath in that way. If you know anybody that's really in ketosis, that's on the keto diet, or is a type 1 diabetic, the breath smells really fruity. Tell them to have a piece of bread and stop eating just like dry chicken all the time. And those kinds of things. But that's what's happening. They tend to have loss of muscle mass because you're going to have metabolism of amino acids in your muscles to try to take protein and use protein as an energy source, often through this ketogenic process. Okay? So that's what's going to happen. Okay. The big issue with type 1 diabetics, the really, really dangerous thing, is something called hypoglycemia. So if I'm hypoglycemic, my blood glucose levels are too low. Okay? Now you may ask, Dr. Black, if I can't drive, if I'm type 1 diabetic, I don't make any insulin, how am I going to have too low a blood glucose if I can't do anything with the glucose that I have? Well, a lot of the issues with hypoglycemia are going to center around mismatching when you eat with when you take insulin, or mismatching when you eat, when you take insulin with when you are active, okay? And so we may see issues of hypoglycemia. I had a student, I shall not name her, it's been several years ago, but we had class at 8 o'clock in the morning. She was a type 1 diabetic, and in all interesting things, I think she went on to go to nursing school, but she did not check her glucose, she did not regulate her insulin very well at all. She told me on the first day of class, I may pass out in class, here is why. I usually have a candy bar or a thing of orange juice or something, and I've also got my insulin in the midst of all of this. Please keep an eye on me, the mornings are bad, okay? Because she just didn't keep track of it. You get up from an overnight fast, you're not thinking about it, you're running out of the house, you jab yourself with some insulin, and you forget to eat your breakfast. Blood glucose drops way, way down, okay? Or you just don't eat, right? And your blood glucose gets too low. It's very often driven by either too much insulin, or as we will see, when you exercise and you're physically active, you drive glucose into your cells. It functions just like insulin. So if I'm a type 1 diabetic, and I take some insulin, and then I go for a run, and I forget to eat something, I'm going to be in big, big trouble because I've got this sort of double-barreled thing driving glucose into my cells. This is the thing that can lead to a coma. It can lead to death. Okay, the brain needs glucose. The brain needs some constant supply of glucose. It functions on glucose. If your blood glucose falls too much, your brain begins to freak out, and its solution is make you pass out and go into a coma so that it will shut down metabolic rate to make it as low as possible in the rest of your tissues so there's enough blood glucose left to make the brain and keep the brain functioning and happy. Okay? So this can be very, very, very dangerous. Okay? Very dangerous. If you have friends that are type 1 diabetics, you've always, always, always got to keep an eye on them and have a candy bar or some fruit juice or some Starburst jelly beans or some kind of concentrated high glucose food around for them, because this can become a really, really issue. Okay? All right. So insulin's an anabolic hormone, right? It drives, in addition to driving sort of glucose in, it also is going to lead to increases in metabolic rate. It's going to lead to increases in protein synthesis. So the main thing that we need to care about is what is it doing in skeletal muscle, what is it doing in adipose tissue, and what is it doing in the liver. And so what it does is insulin, when it binds onto its receptor on these tissues, increases the movement of a receptor that I want you guys to know, or a transporter, called GLUT4. In all of your muscle cells, in your liver, and in your adipose tissue, you're making these glucose receptors that are called GLUT4. When insulin binds to its receptor on those tissues, it tells those tissues to take their GLUT4 molecules, move them to the cell surface, and start grabbing glucose out of the capillaries that are where it's flowing by in the blood. Right? That leads to increases in glucose uptake. So when skeletal muscle and adipose tissue and the liver don't respond right, and it's really skeletal muscle that tends to not respond right, okay, I'm not going to get glucose uptake because the insulin binds, but I do not then get GLUT4 translocation, so there's no signal to bring the glucose in and bring my blood glucose down. That's where a lot of these kind of things are going to play a role. Okay? So this is what this looks like. Insulin-stimulated glucose uptake. Insulin binds to its receptor. This is a muscle cell, right? We've got a capillary here. There's glucose in the capillary. There's insulin in the blood. It binds to its receptor. That then signals through something that we don't fully understand down here to these vesicles that contain this glucose transporter 4, or GLUT4. They move up to the cell membrane. They integrate, and so now I have these GLUT4 transporters on the cell membrane. As the glucose floats by in the capillaries, it binds to GLUT4 and it pulls it into my cells. Thus, now the cell gets some carbohydrates that it can use for energy, and my blood glucose levels have fallen. Okay? As they fall, the pancreas stops making insulin, so there's less binding to this receptor, so then there's less signal to get GLUT4 here. After a period of time, these GLUT4s are going to get recycled, and they're going to move back down into the cell. Okay? That's how this is supposed to work. If I'm a type 1 diabetic, no insulin. So this doesn't happen. Nothing after this step happens because no insulin. I'm a type 2 diabetic. I make plenty of insulin, but when it binds to its receptor, all of this downstream stuff doesn't happen, or happens to a much, much, much reduced extent. Which means then my blood glucose stays elevated longer. I have to make more and more insulin to get the same sort of response then to eventually bring my blood glucose down. Okay? So that's what it means to be resistant in the midst of those things. So something happens and something gets impaired in these intracellular signals. Okay? So you're going to say, well, Dr. Black, we're very smart. We've known this for a long time that this happens. Why don't we know what goes wrong? Well, part of the reason is, look at all of the things that are here, okay? And this is from a several-year-old diagram. I'm sure we've identified more things. But if you look at all of this, here's the insulin receptor. Here's all of these downstream things that are going to play some role in eventually getting GLUT4 to move up to the cell membrane, okay? It's a very, very, very complicated signaling cascade. Very complicated. And so probably we think somewhere here on what's called ERS1 at this place, there's some problems at ERS1, and that's where it's going to happen. We don't really understand kind of all of the hows and the whys that this is going to develop. Okay? So there's some real things, and the ability of ERS1 to activate AKT, and there's some stuff that goes on here. Okay? Eventually, I think, we will figure this out. And when we figure it out, there can be more targeted therapies, there can be better targeted drugs or things, and that we can do a lot more to kind of treat and prevent type 2 diabetes. So, I make no insulin. Can tissues uptake glucose? Yes, of course they can. There are other glucose transporters. GLUT1 is always on, doing a little bit. The big thing from exercise, though, is something called contraction-mediated GLUT4 translocation, otherwise known as the insulin-like effect of exercise. The insulin-like effect of exercise. Okay? I can ask Samantha to stand up and start doing squats for us. And we can immediately, as she contracts her muscles, okay, we can immediately, in the muscles that are contracting, we're going to start moving GLUT4 to the cell membrane to begin trying to bring in more glucose to give energy to those muscles that she's contracting. Okay? So this works. So if I'm a type 1 diabetic, I got to be careful when I exercise because I'm going to start translocating GLUT4 due to contractions. That may lower my blood glucose too much, right? If I'm a type 2 diabetic, that's good. I go for a walk, I go for a run, I go for whatever, and I'm going to lower those things down, which is going to be helpful, but it's also going to have some additional effects, right? Dr. Pinku puts some of these things in here, and I'm not going to spend much time on it. We talk about what are called counter-regulatory hormones. The job of glucose is to lower blood, job of insulin is to lower blood glucose. There are other hormones, though, many of which I am releasing right now because I'm very hungry, right, that are called counter-regulatory hormones that are meant to raise blood glucose levels, to raise blood lipid levels, things that tend to go up either during exercise or if you've gone a long time without eating. And that's epinephrine and norepinephrine, glucagon, growth hormone, and cortisol. We're not going to spend much time talking about these things other than to say that their actions are the opposite in many ways of insulin. Right? So they're meant to mobilize substrates, especially lipids and carbohydrates, so that you have substrate or something that we can metabolize in your blood in between meals. Okay? So we can look at all of this, and what happens during exercise in healthy people is that, weirdly, as you exercise, here's 3 hours of exercise, you will note that blood glucose levels tend to rise a little bit during exercise, but insulin levels are going to fall. Okay? Kelly.
So there's a question on our study guide that says, what are the counter-regulatory hormones and what role do they play in glucose metabolism?
Yes.
So if we're not spending much time on that, then what
I want you to just very, very simply know these four. Know that those are the counter-regulatory hormones.
Okay.
And their job is to raise blood glucose levels whenever they're released.
Okay.
That's it. All right? Good question. During exercise, all of the counter-regulatory hormones are going to go up while insulin goes down. This may seem counterintuitive to you guys, right? You would think, I'm exercising, I need substrate, I need glucose into my muscle cells, right? Samantha's still doing her squats, we need to drive some glucose in there so she has energy. You would want insulin to go up, but that's not what happens. Because the counter-regulatory hormones go up and get us more glucose into the blood. But we have to remember that muscle contractions are driving a lot of that glucose in. And so that's why insulin is allowed to decrease. This is one of the most kind of backwards and counterintuitive things that happens. If insulin went up while you were exercising, every one of us would very likely become hypoglycemic. We would drive too much glucose into our cells. And we become hypoglycemic. Okay? So that's why there's this sort of opposing regulation of all of these things. In general, if you have good functioning, you make insulin, you have good functioning insulin receptors, and you make plenty of your counter-regulatory hormones, and you eat kind of in a normal manner, your body's really, 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 really good at keeping blood glucose levels relatively constant. Okay? It's really good at balancing how much is coming in from what you've eaten, how much is coming in from storage sites like glycogen, and how much muscle and fat in the liver are taking out. So we're normally very good at that, which is why, like, while you're running for 3 hours, you can see it kind of stay pretty constant. It's very good at making that balance. But in people that are diabetic, their insulin function is going to be Don't worry about this. Exercise. Okay. So this is going to show exercise increasing glucose uptake. Okay. So this is the insulin-like effect of exercise that we're going to see here. You do a muscle contraction, and that activates what we think is in some way that we don't understand. We've been studying this again for like 50 or 60 years, and they've not figured out how it does it. They've narrowed it down. Again, we will figure this out, and it will win a Nobel Prize. It will be arguably one of the most significant scientific discoveries ever when we can do all of this, okay, to how a muscle contraction activates the same signaling cascade that insulin does. But you contract your muscles, boom, signal, GLUT4 goes to the muscle membrane, glucose goes into those cells, okay? There's something about stress on the membrane, there's something going on here about the muscle contractions that really seem to activate this, and we don't fully understand, okay? But it's really, really important that that's going to happen. The second thing, this is the place that I'm probably going to leave you guys with today, okay, is if I'm a type 2 diabetic and my insulin receptors don't respond very well to insulin. Exercising, in addition to driving glucose in and functioning like insulin, also seems to rescue my insulin sensitivity. So those same squats that we were having Samantha do, assuming maybe she was a type 2 diabetic, her tissue will respond to insulin better for maybe 2 to 3 days after having done those squats. They're going to look much more like a non-type 2 diabetic person. Okay? You respond better. She's actually going to make more insulin receptors by doing exercise. So there's more receptors, which means it's easier for insulin to bind, and then the receptors that you do have work on. Okay? Exercise improves insulin sensitivity quite a bit. Okay? So we think some of this is related to the body's wanting to replenish stored muscle glycogen in the kind of couple of days after a bout of exercise. Again, a hangover from our hunter-gatherer days where you need muscle glycogen. So if you've got to go hunt tomorrow, you've got to go gather tomorrow, you've got lots of stored carbohydrates. And so you do a lot of activity, it stimulates all of this, okay? And we're going to be in good shape. This effect may last up to 3 days. We see it after walking, running, biking, resistance training, any kind of activity, right? Any kind of activity. So imagine this scenario. I'm a type 2 diabetic and I go walk today, okay? Tomorrow, I don't look like and I don't function like a type 2 diabetic. I'm a regular person. So Bria, when do I need to go exercise again to maintain that effect? 4 to 72 hours is up. So if I walk today, tomorrow, the rest of today and tomorrow, my cells respond more like a regular person. I go walk again tomorrow, and I get another day, and another. So if I could at least go every other day or something, I can, simply by being physically active, okay, I can maybe not completely reverse all of my sort of insulin resistance, but I can have a big impact on it. If I'm a person, regardless of weight status, who is physically active, I am much, 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 much less likely to ever become a type 2 diabetic because all of that activity is helping me to maintain my insulin sensitivity on the front end, okay? So, and then the problem though is I'm a type 2 diabetic, I'm resistant, I stop exercising, and within a couple of days, my symptoms all come back. Okay, so we can use exercise to treat, we can use exercise to prevent, but it has to be very consistent. Okay, for a lot of people that are kind of mildly type 2 diabetic, exercise and then altering your diet, one, to reduce total caloric intake and deal with obesity, but also to maybe cut back on your amount of glucose. Okay, those two things can go a long way to helping us treat kind of early stage, kind of mild to moderate type 2 diabetes. Okay? And so much of it is because of this exercise-induced increase in insulin sensitivity. Okay? Kelly.
Once you have type 2, like, even though you change your diet and everything, do you always have it?
It's a fascinating question. A part of me wants to say yes, you always have it. But you can also make the argument that I've changed my diet, I'm doing more exercise, I no longer have the symptoms of it, right? So do I still have it if I don't have the symptoms? Maybe not, but it's one of those things that, like, I can make it sort of become latent and kind of go away or go into remission. But then if I go back to the other way of doing things, it's very, very likely it's going to come right back. Okay? So it's a good question. All right? My guess is most of you, the people that you know, if they're not kind of like your immediate friends or something, they're type 1 diabetics, the people you know are type 2 diabetics, tell them to go walk today. Tell them to go walk. And then go walk tomorrow, and the day after, and the day after. Okay? It's really, really, really beneficial. Okay. So, boom, 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 exercise as a therapy. This is just showing some data on all of this. You guys don't have to know this. The main takeaway is that, oh, look, exercise as a treatment can be a very useful treatment for diabetes. Okay? We're going to try to work on all of these other kinds of things. This is just talking about what should we do for people that are going to exercise. There's some general recommendations for type 1 and type 2. So the big thing, and I'll just summarize this really, really quickly at the very end. This is Dr. Pinkus, who used to teach this. He is a type 1 diabetic. And so he really likes all of this other kinds of stuff, and he puts all of these things in here. Good gracious, I've forgotten how long this was. Okay, he's killing us with his dissertation here. Summary, take-home message, okay? Exercise is more challenging in type 1 diabetics. Exercise is good for type 2s. It's good for type 1s, but you've got to be careful, okay? Exercise is not inherently dangerous in a type 2 diabetic beyond the normal dangers of kind of high blood pressure and cardiovascular disease. In type 1s, exercise is very dangerous. You've got to make sure that they are properly regulating their blood glucose before they exercise, and you're monitoring it during and after. You don't want them to become hyperglycemic. Okay? That's the big tip. Okay, so we will stop here for today. On Monday, we will talk about some research methods and do what I think is a fun thing in class. So please, if you are comfortable and able to come to class on Monday, that would be a day that I think you guys would have fun if you do class. Okay?